I'm Dr. Larry Dean, the Director of the University of Washington Regional Heart Center, and I'd like to welcome all of you to our grand rounds today. It's my pleasure to introduce our first presenter, Dr. Jim Willems, who's a member of the Division of Cardiology at the University of Washington School of Medicine. Dr. Willems.
Thank you. This is a case of a 55-year-old male who presented with belching, indigestion, low back and left shoulder pain with low-level activity. He had a history of coronary artery disease with prior percutaneous coronary interventions, most recently 6 years previously, but he had had a normal stress nuclear scan 3 years previously. His past medical history is notable for hypertension, diabetes, hyperlipidemia, and a remote history of cigarette use. His current medications included aspirin, ramipril, insulin, lovastatin, rofecoxib, omeprazole, and metoprolol. On exam, his blood pressure was 115/70, his heart rate was 70. He was overweight, but his physical exam was otherwise normal, and his electrocardiogram was normal. He then underwent an exercise stress perfusion study. He exercised 7 METs and developed indigestion and belching, which are thought to be his anginal equivalents, but his ECG tracing was non-diagnostic. These are selected images from his perfusion scan. These are the horizontal long-axis images here. The stress images are in this row, and the resting images are in this row. In this orientation, the anterior wall is here, the apex is here, and the inferior wall is here. And normal perfusion on this study, on these color images, is reflected by the orange area. And you can see on the stress images here, he had an area of decreased uptake in his anterior wall and his apex on the stress image, but this was normal. There was normal uptake on the resting images. This is consistent with a disease in the left anterior descending artery distribution. These here are the vertical long axis images. In this orientation, this is the lateral wall, this is the apex, and this is the septum. And you can see on this stress image there is an area of decreased uptake in the apex and the septum, but the uptake was normal in the apex and the septum on the resting images. Again, this is consistent with the left anterior descending artery distribution. The other thing you notice on this scan is that the left ventricular cavity size is increased on the stress images compared to the resting images. So there's left ventricular cavity dilation with stress, which is suggestive of multivessel coronary disease. Based on this result, on this study, the patient was referred for a coronary angiogram. This confirmed 3-vessel coronary disease. He had a 90% proximal LAD stenosis, an 80% obtuse marginal stenosis, which is a branch of the circumflex, and a 90% proximal right coronary stenosis. These are selected images from his angiogram. This is a left coronary artery, and the left coronary has 2 main branches. The left anterior descending artery is the first branch, and he had a high-grade stenosis in his left anterior descending artery. And the other main branch is the left circumflex artery, and he had a high-grade stenosis in a branch of the left circumflex artery here. This is another orientation of the left anterior descending artery, and this is to show that his distal left anterior descending artery was diffusely diseased, and the caliber of his distal LAD was small. So the diameter of the distal vessel here is smaller than the diameter of our catheter, which is 2 millimeters. This is the right coronary artery here, and you can see he has a high-grade stenosis here in his proximal right coronary artery. So the clinical question that arises here, should this patient be offered coronary artery revascularization with A, coronary artery bypass graft surgery, or B, percutaneous coronary intervention? So here to begin our discussion is Dr. Doug Stewart, who's the director of the Cardiac Catheterization Laboratory at the University of Washington. Dr. Stewart.
Thank you, Jim. Coronary revascularization should be offered, provided his anatomy is appropriate and there are no more comorbidities precluding such therapy. The major issue to consider here is his diabetes. The individual has coronary anatomy suitable for either coronary artery bypass surgery or percutaneous coronary intervention. Another important consideration is the location of his coronary artery stenoses. The most important blockage is in the proximal segment of the left anterior descending coronary artery, supplying about 50% of his left ventricular muscle. The location is of particular importance when considering which revascularization strategy to use. Percutaneous coronary intervention is an attractive alternative to bypass graft surgery for its ability to avoid the morbidity of open chest surgery. Unlike surgery, patients have the potential to leave the hospital the day following the procedure and are able to almost immediately resume their normal activities. In the 1990s, several trials, both randomized and case-controlled, compared coronary bypass surgery to percutaneous coronary intervention. The results of these tests or these studies are consistent. The largest of these trials was BARI, the bypass angioplasty revascularization investigation. This study evaluated patients with multivessel coronary disease and severe angina pectoris with anatomy suitable for either PTCA or bypass graft surgery. 8% of patients screened were enrolled in the study, which included 1,829 patients. Half were randomly assigned to PTCA, and the other half to coronary artery bypass surgery, and they were observed for 7 years. In this highly selected series of patients, similar mortality was seen after 5 years in patients undergoing either coronary artery bypass graft surgery in green or PTCA in gray. Also, there was no difference in the rate of death or myocardial infarction seen in the second group of bars. However, there was a marked difference in the need for repeat revascularization, usually repeat PTCA, in the patients initially treated with PTCA, and this is due to 2 reasons. There was less revascularization initially when angioplasty was used, and more importantly, there was more restenosis in patients who received angioplasty. Restenosis is the process of re-narrowing of the coronary arteries which occurs from 2 to 6 months after PTCA. In this series, restenosis occurred 30 to 50% in the angioplasty procedures in this era. This was prior to the use of stents, which are scaffolds placed inside the coronary artery. And today the incidence of restenosis is approximately half of what was seen 10 years ago, despite treating less favorable anatomy today. An important subgroup was identified in the BARI trial, that of diabetic patients, as this patient is a diabetic patient. Seen on the left, there was no difference in the non-diabetic patient survival at 7 years, whether they received coronary artery bypass surgery or PTCA. However, there appeared to be a marked difference in the diabetic survival at 7 years, with PTCA having a lesser survival than the surgical group, and both groups having a lesser survival than the patients without diabetes. A subsequent BARI trial, BARI 2, is in progress, which will assess, again, the importance of the diabetic subgroup. The explanation for these differences remains speculative. Diabetics have more diffuse disease, smaller arteries, making them anatomically less amenable to percutaneous coronary intervention. And more often there is incomplete or unsuccessful revascularization. They have more silent ischemia and therefore are less likely to recognize when restenosis is occurring, and allowing for the development of myocardial infarction as the first manifestation of restenosis. Also, diabetics have a higher incidence of restenosis itself. So based on the BARI trial, we may ask the relevant question whether patients with diabetes should ever be offered percutaneous coronary intervention, as was the case in this patient. The argument for percutaneous coronary intervention is as follows. Many patients, such as this one, wish to avoid bypass surgery. In his case, he wanted to be married several weeks later. Despite longer-term data, which appears to suggest the benefit of coronary artery bypass surgery, some patients are not good surgical candidates due to comorbidities or coronary anatomy unsuitable for bypass grafting. Recall that even in BARI, most of the diabetic patients with PTCA survive for 5 years. Furthermore, some doubts remain today regarding the validity of the data from BARI. First, recall that only 8% of the patients screened in that trial were actually included. Patients deemed eligible for that trial who did not participate were also followed and did not do as badly. So there may be some question as to the generalizability of the data. From this graph, you can see that the diabetics did worse whether they were in the trial, seen here, or whether they were in the registry. But unlike the trial patients, the diabetic patients treated with angioplasty in the registry did as well as the surgery patients. Probably more importantly, coronary angioplasty and medical management have improved significantly over the past 10 years. The use of stents has dramatically improved the outcome. We now have antiplatelet 2B3A receptor blockers, as well as more use of cholesterol-lowering statin agents. We have angiotensin-converting enzyme inhibitors. And we have a much more aggressive approach to the management of diabetes. But such patients, if they are to be treated with percutaneous coronary intervention, clearly need careful and close follow-up and aggressive medical management. 2 more recent studies have compared coronary bypass surgery to stenting, and these patients have been followed to date for 1 year. ARTS, the arterial revascularization therapy study, and SOS, the stent or surgery study, each randomly assigned approximately 1,000 patients with severe coronary artery ischemia and multivessel coronary disease to coronary artery bypass surgery or percutaneous revascularization with stenting. These trials were completed in the year 2000 and 2001 respectively. You can see that the combined endpoint of 1 year survival free of myocardial infarction and the need for repeat revascularization still favors surgery, seen here on the left. However, in comparison with BARI, the differences between the 2 groups are much less due to a reduction in stenosis with stenting. A curious finding was the reduction in 1 year mortality in the CABG group of SOS at 1 year compared with the percutaneous group. This surgery group had a 1% mortality. The 5-year data is not yet available. In this case, we were able to perform successful percutaneous coronary intervention in all 3 vessels, the left anterior descending, obtuse marginal, and the right coronary artery. Here on the top, we see the location of the stent in the left anterior descending. In the middle of this field, we see the location of the stent to the circumflex vessel. And in this slide, where the arrow is, we see the location of the stent for the right coronary artery. However, the patient had recurrent symptoms of eructation some 2 months later. The decision was made to provide repeat percutaneous intervention for in-stent restenosis of the left anterior descending coronary artery. And here on the top, you can see the location of the in-stent restenosis. There was no in-stent restenosis of the obtuse marginal or the right coronary artery. The technique utilized was a cutting balloon and intravascular brachytherapy, or radiation. On the top, you can see the in-stent restenosis prior to brachytherapy and cutting balloon. And in the middle, you can see the area after it was treated with cutting balloon and brachytherapy. The patient has remained without symptoms for the subsequent 6 months, the time we usually attribute the likelihood of restenosis. Follow-up exercise nuclear testing demonstrated an exercise effort of 10 METs, which was a 35% improvement of what he did prior to surgery. There were no symptoms or ECG changes, and the nuclear scan remains normal. And here are the images shown both before and after, where we have abnormality in the anterior wall, which went away with rest initially, and at the present time we have no abnormality in the anterior wall despite the diffuse disease in that area, and the resting image. I want to proceed with the discussion by introducing Dr. Gabriel Aldea to discuss this case from a surgical perspective. Dr. Aldea is a professor of surgery and is head of adult cardiothoracic surgery at the University of Washington Medical Center. Gabe?
Thank you. Thank you, Dr. Stewart. What I wanted to do is take a few moments and go over much of the same data, but to give you a surgical perspective on it, and to show you that the data can be interpreted in several ways. Again, you're going to be seeing some of this data over again with a slightly different interpretation. So again, the first thing that I wanted to do is again go over the limitations of the interpretation of the randomized trials. And the first point was gone over by Dr. Stewart. Many of the patients that are in the current studies were excluded for a variety of reasons. To be included in the trials, they had to be amenable to both interventions. And the most common reason to exclude a patient from the trials, in my experience, and I participated in a BARI trial, was the presence of complete coronary occlusions, because those precluded the use of percutaneous interventions. So consequently, in all the large prospective randomized trials, less than 50% of eligible patients were enrolled in BARI. And in fact, the patients enrolled are the best case candidates for either therapy. So the applicability and the ability to extend this data to the larger population is limited. In addition, as Dr. Stewart had pointed out, there are the techniques that were used in the trials, which are now almost 10 years old, have been continuously superseded by newer ones. So for percutaneous intervention, there is the introduction of stents and 2B3A inhibitors, and now with special coatings to decrease the risk of restenosis. For the coronary bypass population, there is a very important addition of more complete arterial revascularization, better techniques of eliminating the morbidity of cardiopulmonary bypass when the pump is used, or elimination of the morbidity related to the cardiopulmonary bypass equipment by doing off-pump surgery. And finally, in medical therapy, there's a very important advance in the introduction of statins used routinely, beta blockers and ACE inhibitors, which also would influence not only long-term survival, but also the incidence of restenosis and need for reintervention in both therapy groups. Finally, the most complicated evaluation when we take into consideration outcomes is the fact that we are judging outcomes by intent to treat. So if a patient is enrolled in the angioplasty group, and as frequent as it was frequent in these data, patients cross over to, for example, surgical intervention, their long-term survival is judged as a success by the, in the angioplasty group. So if you look at this, this is very difficult to interpret, and we're judging it as intent to treat. So as you look at these things, the way I would suggest looking at the data is whether or not percutaneous intervention or surgery are reasonable initial therapies, not definitive therapies. Again, if you look at all of those things, let's agree on what's been shown so far, and I'll show you some more data. And we agree that in the prospective randomized trials to date, with older techniques of cardiopulmonary bypass and percutaneous intervention, there is similar clinical survival in patients who are non-diabetic with well-preserved left ventricular function. However, we do know that there is more effective relief of angina in a CABG group, and I'll show you some information to support this in a moment. We do know that despite the fact, as in this particular patient, that the patient was able to leave the hospital several days before with percutaneous intervention, where in comparison to surgery. The return to employment is similar in both groups. We also do know that the neurological effects in both groups and the incidence of dementia was also similar in both groups. There was not a higher incidence of neurological deficits in a CABG group, which was a major concern in the general population. And in addition to it, from an economic point of view, if you look at the costs, they were similar in both treatment groups. From a societal point of view, the cost of repeat interventions is significant, and the cost both from a personal and a societal point of view was similar. In fact, in CABG patients treated in patients treated with CABG in the BARI trial, the cost of therapy at the 5 and 7 year marks was less with CABG than with percutaneous intervention. Now, again, this is a point that Dr. Stewart made before. In every single trial that was done to date, the incidence of reintervention with CABG was significantly lower. In fact, it is 6 times higher with percutaneous interventions. So many patients who undergo a prior angioplasty will require a repeat percutaneous intervention or surgery or both. So this is the main finding of the BARI trial and the EAST trial, and you see also several of the European trials. What are the new technologies? Well, since the trials were done, there are several evolutions in technologies. For the surgical side, there was a major improvement in the way surgery is conducted. There is a development of biocompatible circuits and techniques for surgery to decrease the morbidity of bypass when surgery is done with a heart-lung machine. So the old heart-lung machines and the techniques have changed dramatically. There is an introduction of off-pump CABG, which allows us to immobilize a very small segment of the heart, allow the heart to beat, avoid cardiopulmonary bypass altogether with very effective short-term results. And also there is introduction of stents, and now with the Revel trial and sirolimus coating, the possibility of significant decrease in the restenosis rate. But again, just to look at the long-term outcomes, we know that the patency of a mammary artery at 10 years is over 90%. It's close to 97, 98%. Similar results have been obtained with a non-pedicle or right mammary, a second mammary bypass. And we know that now that we can add to this the possibility of using more arterial grafts with a radial artery, another useful arterial conduit. So in a patient such as this, we would consider multiple arterial grafting, knowing that we can have not only a single but double arterial grafting, and to decrease the risk of reintervention in the future, minimize it to very close to zero. Now, you've heard from Dr. Stewart the discussion of the ARCH trial, and I think the ARCH trial deserves a little bit more careful evaluation. This is one of multiple new trials. Again, this is published in the year 2001, involves essentially comparisons of stents versus arterial revascularization for CABG. 90+% of the patients had arterial grafting. The acute morbidity is the same for both groups. But let's look a little bit more carefully. The need for in the diabetic population, the event-free survival at 1 year is 84% in the CABG group versus 63% in the stent group. And for the non-diabetic population is 88% in the CABG group versus 76% in the stent group, with a much higher incidence of either needing repeat procedures in the form of CABG or angioplasty. So in addition to it, what we see is that survival, the disease-free or event-free survival with surgery, is not really significantly affected by the presence of diabetes. It's only modestly reduced, whereas the event-free survival for diabetic patients is significantly less. It's substantially reduced from 76%. So in summary, I think there is a tremendous evolution both in percutaneous interventions and in surgical technique. I think that at the moment, the preponderance of data in patients with diabetes is such as to support a surgical intervention with arterial revascularization in these patients. So for this particular patient, they do not have an excessive risk for surgery, and the possibility to afford them a long-term survival and freedom from reintervention is significantly higher with surgery than with current stent technology. Again, I think we have to be very judicious. At the University of Washington, we usually make those decisions together, and typically it is clear which therapy is best for a specific patient in the long course of their disease. I thank you.
Thank you, Gabe. I want to underline and support that the comment that certainly the preponderance of evidence for the randomized trials that exist to date does suggest that coronary bypass surgery is a good solution. I want to underline particularly the emphasis on the number of vessels that are totally occluded that cannot be treated with intervention. But I think the overall emphasis we want to place here is the individualization of treatment in a situation where we can sit down and discuss these patients together. At this time, I'd like to entertain any questions from the audience.
I think it's very important when you look at this data, as Dr. Aldea has pointed out, that we look very carefully at what's been presented. And I think any time that you use an event as repeat angioplasty, which we all know does commonly occur in patients undergoing angioplasty, if you use that as part of your event-free survival, angioplasty will always have difficulty, at least with the current technology, because of restenosis. So if you look at this particular slide that's being shown here, I mean, there's not death on that slide. It's comparing event-free survival here is being defined as CABG angioplasty, and I don't see death on the slide. So I think it's important to look at that slide very carefully. And because the failure mode of angioplasty is restenosis, it's going to be always somewhat disadvantaged when you look at that.
I'd like to ask Dr. Aldea a question. One component that has not been touched on much here is the increased morbidity of bypass surgery versus angioplasty. Such things as infections, renal failure, congestive heart failure, these were seen much more commonly, particularly in diabetic patients in the surgical arm of, say, the ARTS trial, where nearly half of the diabetic patients had to come back to the hospital for some of these serious comorbidities. Given the comparison of these comorbidities compared to repeat coronary angioplasty, which is usually handled as a single-day admission, at which point the patient is able to go back to their normal activities, should we not be incorporating these very important events, which are more traumatic than angioplasty, into our consideration of which revascularization to offer?
Let me use this microphone. Well, our experience, certainly less than half of the patients come with any kind of complications, and I think that, again, in our own personal experience, we've looked at the post-BARI universe in Boston when I was on faculty there, and we found out that once you allow for differences in demographics of patients who are referred for CABG versus those who are referred for angioplasty, the most common explanation for the complications is different in demographics. In fact, if you look at the incidence of stroke, major pulmonary complications, and infection, they're almost patient risk variable related, and they're independent of the choice of revascularization. Certainly, when you're doing bilateral arterial grafts and multiple arterial grafts, we can deal with this and decrease morbidity of sternal infection with a single mammary in our radial artery. And in fact, the incidence of infection in our hands in diabetic patients is well less than 1 or 2%, which is the national standard.
Well, I'd like to thank the audience for their questions, their attention. I'd like to thank our presenters for their excellent presentations, and I hope to welcome all of you back to another Grand Rounds in the future. Thank you.